I'm Peter Block here in Chicago at AHA at the annual meeting, and it is day 4, the last day. I'm here for On the Scene, and with me is Deepak Bhatt, and we're reviewing the breaking clinical trials of day 4. So Deepak, today we have Basket Prove 2.
That's right.
An interesting trial that is an important one to talk about, I think, about. What are your thoughts?
I think so. It's a trial that randomized patients to 3 types of stents: a very good bare metal stent, a very good second-generation drug-eluting stent with a durable polymer, that is, the polymer stays, and then a drug-eluting stent with a biodegradable polymer. Not a biodegradable stent, but the polymer is biodegradable.
Important difference.
That's right. And the main result was that there's lower TVR with the drug-eluting stents, either flavor versus bare metal stents. Not that surprising, I suppose. But the hope had been that there'd be greater safety with the stent with a biodegradable polymer, and in fact, that wasn't the case.
Yeah, there seems to be very little difference between these 3, except for the bare metal stent, where, as you might imagine, boom, there it is, more outcomes. TVR primarily.
Yes.
Right? And we're talking really about restenosis in that group, rather than stent thrombosis.
That's right. And I think it shows that it's hard to beat the current second-generation drug-eluting stents. They're pretty good.
Yeah. You know, I think this trial tells us that what we are currently using is pretty good stuff.
Yes,
and
both in terms of efficacy and in terms of safety.
Absolutely. And the biodegradable polymer, you know, adds maybe a little flavor to it, but not a whole lot for me anyway. For you?
I agree with you, and it's not available in the U.S. anyway.
Yeah.
It is available in other parts of the world. So I think the second-generation drug-eluting stents we've got in the U.S., they've been well studied, good efficacy, good safety in terms of both early, late, and even very late stent thrombosis. So I think we're in good shape with what we've got.
Okay, moving on, there is one other one today which I thought was of interest. When I first saw it, I thought this is going to be a really interesting trial, the AVOID trial.
Oh, yeah.
Oxygen therapy for patients with acute myocardial infarction.
That's right.
Your thoughts?
I think, first of all, it was really an interesting study because it was examining in a randomized fashion whether giving oxygen to patients with ST elevation MI is indeed warranted. That's, of course, a common practice. Any hospital emergency department you walk into, someone will slap some oxygen on you. And to study in a randomized fashion, really brilliant. And as it turned out, no benefit from being on oxygen versus just being on air.
Yeah, no benefit, and there is a signal that maybe it's not so good for you, which is very curious in terms of recurrent myocardial infarction, particularly early on, within the first 30 days.
Yeah.
You know, Deepak and I were talking about this before we came on air, and why should that be? Why should oxygen therapy actually give you a higher incidence of recurrent infarct? I thought maybe it had to do with coronary vasomotor tone being greater if you have high oxygen, and the coronaries to think that they're in great shape when in fact they're not. There may be other reasons as well, oxygen toxicity, who knows? But certainly these data don't give us an answer to that one. Yeah, but clearly the signal is there.
Absolutely, with no signal of benefit and some signal of harm, you know, why do it? I mean, granted, it's relatively easy and cheap, but still never been evidence-based, and now there's some evidence suggesting a reason perhaps not to do it.
So, I have a question for you as far as that's concerned. Now that you mentioned it, just came into my brain.
Oh,
so if you have a patient that comes in the ER with an infarct, and they're in pulmonary edema, and their oxygen sats are down around 89 or 90, would you give them oxygen?
Oh, sure. So if someone is actually hypoxemic, then I would give them oxygen for sure. But in someone that doesn't have hypoxemia, I would avoid just the routine slapping of 2 liters of O2 on them. That doesn't appear to have any benefit, might have some harm.
Yeah, I agree. That's the clinical message. Thank you, Deepak.
Thank you.